I'd like to start by thanking the members of this committee for opening this up for public discussion, because I think it's really important that we come together to discuss this topic. I think it's absolutely critical, and so my name is Michael Galipeau, and I just want to clarify that I'm the president of the Rhode Island Users Union. And as such, a person who's been convicted of multiple counts of sales, manufacturing, and distribution, and also a person in long-term recovery who's struggled with substance use, that I'm the first person to sit at this table to talk with you guys about what the decision is that you are making today. Okay. So the most significant part of this bill that I see as somebody with both sides of the experience is that there's very little distinction in the relationship between users and dealers at the street level. Even at the middle and upper echelons, all of these areas, the people who are distributing these drugs have very little control over the supply that they obtain, as much as 85 to 90%. And as far as what I'm testing as a social worker, I'm able to work closely with my clients. And what I'm observing, and I use this as a tool for education, when I administer drug testing, is to have conversations about user safety and to talk about what we're finding alongside of the drugs that people are buying. It's in the crack cocaine. We verified it's in the methamphetamines. It's showing up in literally every single drug available on the street. You cannot buy a drug today without it. And unfortunately, as we continue to tighten the belt around the supply lines, and as we continue to increase pressure on communities of use, it will have very little, if not no impact whatsoever on demand. And so people will continue to turn to available means to satiate their cravings and their disease. There is no rationality behind it. There is no logic or reason. It is visceral instinct for survival. When you are in the throes of withdrawal, there is little way of persuading somebody to do something other than take their own life, if necessary, to satiate that craving. Being a survivor of overdose, hearing a bill like this, if I were the person holding that plunger to my arm, I would tell my friends to back away and leave. Whatever happens may happen. Do not call the police, because I do not want any of my friends to go to jail for life for my decision. And I think there are many users that understand this. And I think there is no way to implement an overt policy like this without generating significant fear amongst an already highly impacted and stigmatized community. You cannot preserve the Good Samaritan law and expect people who interchangeably change roles to then feel safe to contact the authorities in the event of an overdose. It is impossible. That is not the message that you send. The message that you send to embrace communities of use are options like law enforcement assisted diversion, an expansion of the existing Providence Safe Stations program, piloting medically supervised evidence-based safe consumption sites where people can go and have a safe space to use, where the incidence of fatality within those facilities in Vancouver, Canada today is 0. Increasing access to viable measures to eliminate the death from overdose. That is the relevant conversation. Increasing penalties for folks who are experiencing overdose, who interchangeably change roles, will have 0 impact to reduce the incidence rate of overdose death in the state of Rhode Island, and I am absolutely certain you will see an opposite effect. As a representative of the community of use, I strongly urge this committee to take action against this bill and to promote reasonable solutions. Thank you.
Thank you, Michael. Any questions? Yes, Vice Chairwoman McEntee.
Thank you, Mr. Chairman. Michael, how has the Good Samaritan Act impacted the community that you work with?
So there are several things that happen that are very beneficial for communities of use as a result of that bill. The first is we can promote users to use in groups. where the ability for somebody to intervene and contact emergency services is increased because A, you have a second party there to administer naloxone in the event of an overdose, to contact 911, and people, because of this gray area for responsibility around the transmission of substance, it's very difficult for people to feel confident in their ability to do that when they're already marginalized largely by the police. Among the front of this conversation, the recent data analysis that I conducted on the last 60 days of Providence Police data shows very clearly that communities of underprivileged individuals within the Providence area are significantly and disproportionately represented. That would be the scope of impact of this legislation. The A2A or A1A and A1B portions of the legislation that prosecute low to middle level distribution crimes. These are the crimes that would be specific to the targeted group or focus group for this legislation, represent biracial Hispanic and Black communities at 889% of their occurrence in the general population. I can go on. The Hispanic communities at 33% are represented at 157% of their representation in the general population. For Black communities, for residents in this city, 289% of their occurrence in the general population. The overt impact of this bill and this legislation being passed would very heavily increase criminalization along racial and ethnic and class lines. And I think that to look at this view as anything other than what it is very nearly overtly racially discriminatory, as is the war on drugs.
Representative Price.
Thank you, Chairman. Very powerful and enlightening testimony. So it sounds like this, your thoughts that you're describing are that this is going to affect the end user of the drug, the chain of the drug use, and the money will flow down to the end user, and the end user will be the one that's punished. Am I correct in what
The
you're
end
saying?
user and distributor are most oftentimes indistinguishable. And so generally in law enforcement practice, the way that prosecution handles such cases is they go as far up as they can go with the looming threat that if they cannot put somebody else on the hook who's higher up than them, then they're the one left on the hook. And unfortunately, even at the highest levels of supply lines that we have here, we have largely producers in other countries that have manufacturing facilities that utilize exploitation of underprivileged individuals in other countries to traffic drugs through our own systems. Largely, our postal system plays an unknown party to the transmission of drugs and substances across borders and around the country. And we can't prosecute those individuals. We have overdoses that occur from doctors prescribing medications, but we don't charge them with murder. Under this bill, it would meet the statutory description because the pharmacist sold them the medication. I think this is a ludicrous bill that is an inadequate way to address a public health crisis. Criminalization is not public health. Medicalization is public health.
So I think the intent of the bill and the body is not to, is to really address the opioid crisis. And I have to agree with you that it's, if I'm understanding correctly, it's at a much higher level that we should be addressing this. Is that what I'm understanding?
Recently they came out with a documentary on HBO called Meth Storm. I don't know if you've had the opportunity to review it, but there's a really telling testimony from the DEA officer who's worked cases just like this for 25 years. And he feels overwhelmed and he feels hopeless because time after time after time they are arresting their own local community residents that are not the manufacturers, they're not the distributors, and try as hard as they might, they do not have the resources and they do not have the ability to go into international jurisdictions and pursue these cases where they should rightfully be fought. So they end up going for the biggest fish that they can get, the low-hanging fruit. And those are the people that end up bearing the consequences of legislation exactly like this.
Okay, thank you. I guess I would encourage our body to look deeper into the situation and actually find out where all these opioids are coming into our country and at the higher level address it there rather than at the end user. So thank you for your testimony, and I appreciate your passion. Thanks.
Thank you, Representative.
Representative Vella Wilkinson.
Thank you very much, Mr. Chairman. Michael, thank you for your testimony today. And to the other parents and friends of individuals who unfortunately had perished at the hands of overdoses, my sympathy and prayers go to all of you. Michael, I appreciate the fact that you've been so honest with us with regards to what your history had been prior to becoming a social worker and working with the community. So I'm going to ask you a couple of questions. If you don't feel comfortable answering, or if you feel it's inappropriate, you're not going to hurt my feeling if you say I'd rather not say. I'm just trying to understand exactly what's going on. When you were in a situation where you were purchasing for either your own consumption or for resale, did you typically purchase from the same person?
No.
So how would you know who you were going to and what the quality of the drugs were that you were purchasing?
So for my own practice was, I would say, rather atypical. So while I was out there in the drug community, I largely, participated in similar practices to what I promote for public health solutions, which is I would acquire dance-safe test kits, and I would rigorously test drug supplies. In fact, I entered into a lot of educational conversations with other low-level dealers to teach them about the products they were selling, because largely I found people in the community had no idea what it is that they were selling people. We had people selling Suboxone as ecstasy pills, and they actually thought that's what they were. I mean, people were extremely uneducated in what they were doing, but because of their addictions, they were participatory in a process that they then had to respond and adapt to meet a visceral need. I will say that it has been an extremely difficult experience for me being a person. I grew up in Willimantic, Connecticut, which was very early in the heroin epidemic, put under a microscope. Under 60 minutes, we were dubbed the heroin capital of the East Coast. So the place that I came from, my roots where I grew up in this, these issues around user safety were extremely magnified. And it was an early indicator of what's now been spreading and happening throughout the country. So the things that I did as a dealer were largely a response to my compassion for the people that I was serving and my concern for other people's safety. I had people that were coming to me getting beaten up and robbed when they were going to get drugs. I had people coming to me that were getting drugs and not getting what they were paying for and then getting sick. And this isn't even, this is prior to the advent of the insertion of fentanyl, which virtually nobody has control over at this stage, at least not on the local scene, because we're not producing it. So to think that folks out there have the knowledge and the tools to be responsible in making decisions that lead to somebody's accidental death, I think that is the critical part of this conversation that we lose, that these tragic incidences, including many of my own best friends, the people I grew up with, they died from accidents. They didn't intend to overdose. They didn't intend to die. Nobody's out there distributing test kits like the organization that I formed, the Rhode Island Users Union, proposing to do through writing grants and getting funding to do that. Nobody's currently doing that. So people don't have the educational tools to make informed decisions.
Michael, is it fair to say, however, that if someone is either dealing or selling synthetics, where we saw the pictures, and it's on the desk right by you, that 1 to 2 grams could potentially cause instant death? If someone is selling something that's that lethal, the expectation, wouldn't you say, is that it's going to cause the death of the end user? It's not going to be accidental if not you, of course, but if someone is distributing a toxic element that the Nican isn't going to help, that if they take 2 grams of it, they're going to die instantly. How could that not be done with the intention of killing the person? We're not dealing with Superman and Superwoman on the streets.
So we have had other drugs in the past that similar amounts would have similar lethality. I mean, LSD has been out since at least the 1950s, and anybody who consumed 2 grams of LSD would never come back. And that's just a frank fact. But the fact of the matter is we have people selling drugs that are not necessarily even knowing that there's fentanyl present. They have no control over the fact that there's fentanyl present. And there's an existing demand, both personal and market-wise, on the street that is not being met otherwise through proper regulated channels. The lack of regulated markets and controlled sourcing is directly responsible for the presence of fentanyl. As we've continued to tighten the belt around the other illicit substances that people who are addicted demand, people have sought and found additional new creative ways to meet that demand in a way that's accessible and affordable. That is natural economy. There is no law enforcement that will overcome the natural effects of supply and demand. The only reasonable intellectual response is to implement planful economy.
Thank you, Mr. Chairman. Thank you, Michael.
Representative Price.
Planful economy?
Planful economy, regulation, market regulation. They're doing this in Vancouver now. They just set out their first set of opioid dispensary machines. They're modeled after the same machines that they're using for dispensing marijuana in Europe. And they're finding that these practices, both in Portugal and in Canada, are having a significant increase in correlation to user safety and a decrease in the incidence of death. Well, if you compete them out, the ferreting of bad actors happens naturally in a healthy economy. So yes, you would compete them out. People largely aren't going to the market to buy fentanyl. They're not. The vast majority of people are not seeking fentanyl. So if you give them a means of obtaining what it is they're actually looking to get, you'll increase consumer safety because they're aware of what they're getting and in what quantity. Just the same way that we administer alcohol. You know, people know what it is that they're buying and they can make informed decisions about how to safely consume it.
Thank you.